professor, physician, epidemiologist. I am Dr. Sri Banerjee. Hello everyone, I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University with a joint faculty position with Ross University School of Medicine. And today, in this video, what I'll be doing is focusing on understanding the different applications of race correction and how this has been called to question in recent years, and how this has actually affected clinical medicine in so many different ways. So this was actually published on August 27 of 2020. By multiple authors who collaborated on this. And this was, what I did is actually rotated this table so that we can study just this table. This is part of a paper, and we can look at it kind of on the side, hidden in plain sight, reconsidering the use of race correction in clinical algorithms. And I can actually rotate that for a second, and then you can tell you can look at this quickly. But understanding of race has changed. Let's face it. What was there in 2003? This is looking at 2003. Human genetics, our understanding of the impact of human genetics on considering race, and how all of that has evolved into a more complex discussion is important. So it's embedded insidiously within medical practice, this understanding of race and the correction for this. Now, in epidemiological studies, it is common practice to control for race and to understand the effect in some ways. But when you're actually converting some of these to algorithms, caution must be exercised. And simple reason is this. If we think of race as a social construct, the differences in individuals that belong to the same racial group a lot of times are more than individuals who belong to different racial groups. And so this is the simple reason why it's difficult to have one risk scoring system that applies everywhere. And so we're looking for algorithms to create more specialized risk scoring system. That is still the case. That has not changed. But what has changed is understanding and making sure that the corrections that are being made are not from outdated models that had not even considered some of the different races, and that is the argument that's being made. What is really interesting about this 9-page article is it goes into nephrology, it goes into obstetrics, it goes into cardiology, it goes into many different fields. So if you're a medical student, if you're a resident, if you are in the field of medicine, this should be a must read for you. So just looking for now looking at the table, how it was, and I'm gonna just read through some of the quick equity concerns out of these. Looking at cardiology to begin with, and understanding heart failure, acute heart failure. Clinicians are advised to use this risk stratification to guide decisions regarding initiating medical therapy. So some of the input variables are systolic blood pressure for heart failure, blood urea, nitrogen, because you have to monitor the kidneys, sodium, age, heart rate, history of COPD, black or non-black. Add 3 points to the risk score if the patient is identified as non-black. This addition increases the estimated probability of death among non-black individuals. So, what's the equity concern in all of these? The original study envisioned using the score to increase the use of recommended medical therapy in high risk patients and reduce resource utilization in those at low risk. The race correction regards Black patients as lower risk and may raise the threshold for using clinical resources for Black patients. Um, so if you raise the threshold, then Black patients are not as readily treated for heart failure. Cardiac surgery. Where's their equity concerns? Well, first of all, the scoring system calculates a patient's risk of complications and death with the most common cardiac surgeries. So considers greater than 60 variables, some of which, of course, are listed here, but operation type, race and sex, and race. If you're the default setting is Black, Asian, American, Indian, Hispanic, Latino, and then BMI. The risk score correction for operative mortality and major complications increases in cases by 20%. So if a patient is identified as, especially if the patient is identified as Black, so operative mortality is increased by 20% if the patient is Black. Identification as another non-white race or ethnicity does not increase the risk scoring of death. But it does change the risk score for major complications like renal failure, a stroke, and prolonged ventilation. So when used preoperatively, what does this all mean? When used preoperatively to assess a patient's risk, these calculations could steer minority patients deemed higher risk away from these procedures. Um, so it's really important to apply this risk accurately before conducting surgery. Now to nephrology, and this is something that I've been following actually personally. Um, Initially, there was a physician in Philadelphia for the University of Pennsylvania that really spearheaded the campaign to nationalize understanding of the effective GFR calculated through the MDRD and the CKD epi equations. And both of these equations can be found, and I've studied both of these in this link that has been provided. But in very simple terms, this measures level of chronic kidney disease, the effective glomerular filtration rate, which is measured through serum creatinine, age and sex, and Black versus white or other. So the MDRD equation reports a higher effective glomerular filtration rate if the patient is identified as Black. Now that's a problem. This adjustment is similar in magnitude to the correction for sex. So that's a problem because that means that kidney function a lot of times may not be as optimal as this race correction is making it out to be. Similarly, in the CKD-EPI equation, which included a larger number of Black patients in the study population, proposes a more modest but still a race correction. What happens? Both equations report a higher effective glomerular filtration rate values, and as I said before, for patients identified as Black, suggesting better kidney function than what it actually is. And what happens then is you're catching renal disease and renal failure much later when it's too late. So this has a potential to be addressed, and one way to do this is to look at multiple types of equations and see which one performs better with the race correction and without. So looking at these types of corrections need to be looked at in many different disciplines. That's the bottom line. Organ procurement and transplantation network, when kidney donor risk index, things like that. in the area of obstetrics. This is an important area in terms of the vaginal birth after cesarean risk calculator. And then in urology, the stone score, which actually predicts the risk of a ureteral stone in patients who present with flank pain. And there's a correction that is made on a 13-point scale with a higher score indicating a higher risk of ureteral stone. And 3 points are added for non-black race. This it makes systematic lower a risk for black patients than for all non-black patients. But this continues onto oncology with rectal cancer survival calculator, National Center Institute breast cancer risk assessment tool, breast cancer surveillance consortium risk. So these are all in the areas of oncology. Then if we move on to the last two systems, endocrinology and pulmonology, looking in endocrinology, the osteoporosis risk score. This is in fact a simple calculated osteoporosis risk estimation. And input variables, interestingly enough, rheumatoid arthritis is one of them. History of fracture, age, estrogen use, weight, race. Now the race correction here, if assigns 5 additional points if the patient is identified as non-black. And again, this is lowering the estimated risk of osteoporosis automatically in all black patients. And you can't do that because the race of black is in many times so broad. And so this may not apply everywhere. So similarly, and that one was through a DEXA scan. Similarly, the fracture risk assessment tool is a 10-year risk of a hip fracture and osteoporosis, adding 5 points for non-black, and then the fracture risk assessment tool, that was for the other one. For this one, the U.S. calculator returns a lower fracture risk if a female patient is black, Asian, or Hispanic. Other multiracial, it's not really recommended. The calculator reports 10-year risk of major osteoporotic fracture for black women as less than half that for white women with identical risk factors. And then finally, we talk about pulmonology, the pulmonary function tests, and that uses spirometry to measure lung volume. And I actually recently talked about this, and the rate of flow through airways in order to diagnose and monitor any sort of pulmonary disease. And the input is age and sex, height, race, and ethnicity. In the U.S., spirometers use correction factors for persons labeled as black, 10 to 15%, or Asian, 4 to 6%. Inaccurate estimates of lung function may result in misclassification of disease, severity, and impairment for racial and ethnic minorities in asthma and COPD. So lung function it is not as accurate in individuals of other ethnic groups, and maybe other types of tests need to be done. So that concludes in broad strokes what this risk scoring entails. And as you can see, there's a lot of considerations to be thinking about when you look at risk scoring. It's not something that that contains only a few factors. And just going through this discussion a little bit, researchers are aware of dangerous terrain. For instance, thoracic surgeons acknowledge concerns raised by clinicians and policymakers that inclusion of socioeconomic status factors in risk models may adjust away disparities in quality of care. Nonetheless, it proceeded to consider all preoperative factors that are independently and significantly associated with outcomes. Race has an empiric association with outcomes and has the potential to confound the interpretation of a hospital's outcomes, although we do not know the underlying mechanism. This differential effect needs to be considered in the context of different approaches and different models, and arguably some of the epigenetic factors and epigenetic studies and polygenic risk scores and variants are better addressing these issues in different ways. So is the need, the question remains, actually three questions. When developing, and because algorithms need to be created, this is not a deterrent to create algorithms and AI-informed algorithms. It's to inform them. So we propose, it says, the researchers propose an adaptation of these guidelines to evaluate race corrections in clinical settings. When developing or applying clinical algorithms, physicians should ask three questions. One, is the need for race correction based on robust evidence and statistical analyses, with consideration of internal and external validity, potential confounders, and bias? Number two, what should be considered is there a plausible causal mechanism for the racial difference that justifies the race correction? And then three, would implementing this race correction relieve or exacerbate health inequities? And so it's not a simple sort of solution of seeing and creating an algorithm. It has to be ethically based, and also understanding from a social determinants of health perspective. It's not broadening inequities and maintaining equity. So this is about risk scoring. This is all that there is, and there's as you can see, this is something that is needs discussion in many disciplines in medicine. Thank you for listening.